Good afternoon, dear friends. We are pleased to present our work on online macular hole outcome predictor in macular hole surgeries. Now, irrespective of the sophistication of our machinery and the elegance of our techniques, we need to give a scientific answer to our patients whom we are going to operate. The patient wants to know, doctor, how much I am going to see. Now, this is more true for macular hole surgery, where most of the time we tell the patients we will try our best, but the patient wants to know slightly more. As we can see in the international literature, the hole closure rates are suboptimal, the visual success rates are suboptimal, and even visual loss can be documented in macular hole surgery. So based on this premise, if we study the international literature, various OCT parameters have been studied to predict outcomes after macular hole surgery. A meta-analysis of all these predictors was done and presented in 2014, which concluded that the minimum linear diameter was the most reliable parameter which predicts the outcome of macular hole surgery. Also, some of the few other parameters like hole form factor, macular hole index and tractional hole index were believed to be of some help. But unfortunately, the most reliable parameter, that is macular minimum linear diameter, does not always work, as seen in this patient who has got a poor type 2 closure and a non-closure and a poor visual loss after surgery in spite of having a 300 microns macular hole. Also, the other problem is that a busy practitioner does not have time to calculate all these indices real time in his clinic when he sees the patient. So the aim and objective of our study was to develop a free, easily accessible, that is an online macular hole outcome predictor. And this predictor and nomogram should work irrespective of the hole size, irrespective of the etiology, whether it is traumatic, idiopathic, and irrespective of the surgical technique, whether you want to do a traditional macular hole surgery or the ILM PLAF surgery. So irrespective of the macular hole surgical technique. So this was based on a retrospective statistical analysis of a single surgeon, 50 cases of macular hole surgery, which were operated by a single surgeon. And then this nomogram was statistically analyzed. We used the logistic regression analysis and we studied each single OCT parameter and found that no single parameter can reliably predict outcome in all situations. So what we concluded from our regression analysis was that we have to use multiple parameters in every case. So what we designed our nomogram was, we use 6 parameters, that is minimum linear diameter, the ELM integrity, the cystic edema of the hole edges, the macular hole index, hole form factor and tractional hole index. Using all these 6 parameters, we developed a scoring system, and this nomogram is designed to answer 3 questions. Whether the hole is going to close, that is the hole closure rate prediction, whether the vision is going to improve, that is the visual prediction rate, and whether the chance of visual loss after surgery is there, that is a visual loss predictor. So this nomogram will address these 3 issues. Now let's study whether this nomogram works with some case examples. The case which we showed previously, that is a poor type 2 anatomical closure and loss of vision outcome after surgery, is explained by the poor scores for anatomical closure as well as visual success in this nomogram. Whereas a similar 400 microns hole has got excellent type 1 closure and very good visual outcome, that is from 3 meters to 6'9", and it is explained by accumulating very good scores on the anatomical as well as visual outcome parameters. Now a large hole. This is a 988 microns hole, and we used a inverted ILM flap technique, and we can see that the vision has improved and there is a type 1 anatomical closure. And again, it is scientifically explained by the scoring system of the nomogram, which gives good scores for both anatomical and visual success. Now a similar inverted ILM flap technique was used for this slightly lesser sized hole, but you can see that this hole, though it has closed, there is a vision loss and poor outcome after the surgery. Again, on the nomogram, you can see that very poor scores were accumulated for this particular patient. This young patient of traumatic macular hole improved from 3 meters to 6'9", and again it is showed that by this nomogram, he has got a very good visual outcome and improvement prediction rate. Now how easy is it to use this nomogram? So we have to just go to the website and type www.drmacula.in, and there is a guidance where you have got even your a technician who is operating the OCT can do these parameters. He has to do these measurements, 6 measurements: minimum linear diameter, right arm length, left arm length, basal diameter, and hole height. And then there is also a guideline for evaluating the grading of cystic edema and ELM integrity. So based on this, you will get a score, and a score of more than 4 will give you a good outcome. So we conclude that we have designed an online macular outcome predictor. This is quite easy to use, and it is reliable and predictable, irrespective of the hole size, the etiology of the hole, and the surgical technique, whether ILM flap or no flap technique, traditional technique. And so we believe that this is very useful in pre-operative counseling, surgical planning, and also to audit your own outcomes after surgery, what went wrong. These are the references. Thank you.